Hi, everybody. As we're just waiting for more people to join and hope to start at the top of the hour. As you join, you'll see some demographic questions. If you could please answer those, and you just have to scroll to the bottom. There's three questions. So as you come on, if you see those demographic questions, if you could answer those, please, and just again scroll down. Thank you. Hi, everyone. We'll just wait for another minute. If you see the demographic questions, if you could please answer those while we wait for a few more participants to join. Thank you. Okay, so I think we'll get started. I know some of you are joining. If you saw some of those demographic questions, if you could respond to those if you see the poll. And we will go ahead. So welcome everybody to our fifth part of our six-part series on substance use disorder treatment in individuals with HIV and those at risk for HIV. Thank you for answering the demographic questions. So today's particular talk is on stimulant use disorder, harm reduction, and management in patients with HIV. I'm super excited to be involved with this and hear our speaker, who today is Dr. Stephen Shoptaw at the University of California, Los Angeles. And I am Sandy Springer at the Yale School of Medicine, an infectious disease addiction medicine clinician, and we'll just be moderating the session today. So just to remind everyone, if you've been to some of these sessions, and then for those who this is your first time, that this particular session, along with the full six-part series, meets the requirements for the DEA training, new DEA training, for those who have a controlled substance certificate, and it comprises 8 hours of that requirement. So you can also go to the IAS-USA website, and you will see a full area on the DEA compliant CME Resource Center, which includes all of the pre-recorded sessions to date, and then we'll include this one and the subsequent ones. We also always like to remind you of the National Substance Use Warm Line, which is a cost-free, confidential clinician-to-clinician teleconsultation phone number that you can call to ask questions about addiction medicine and HIV and get responses quickly. We do like to remind you that all financial relationships with ineligible companies are all vetted. And here you can see our content on the web board members who do that. Our relationships for both myself and our presenter, Dr. Shoptaw, are presented here. And then also to remind you, for those who are interested in CME, that this is categorized as a 1.5 AMA PRA category credits for attending this. And you can also see here that this activity has been approved for up to 1.5 CME credits for those for ABIM mock, nursing, pharmacotherapy, and pharmacy credits. We would also always like to acknowledge the generous support for this particular activity that has been received from these supporters. And just some baseline information. Please put all your questions in the Q&A button, not in the chat. And then you will also see poll questions that are coming up in a separate window. And then you just choose your response, and then the responses will be displayed afterwards. So it's my pleasure now to turn this over to our presenter today, Dr. Shoptaw. Take it away.
Thanks, Dr. Springer. I'll be right with you here with this. All right. And I'm going to come up to here. In presentation mode and minimize this. Oops. Okay, so these are my disclosures. Just to get a sense of who's in the house, if you could just click your job title that you perform in your HIV setting. Please make it one single choice. While you're doing that, I want to thank the organizers of this series, particularly IAS-USA. I think the idea of focusing on substance use in the setting of HIV is brilliant, because that's where our patients are, because when they're not seeing me, they're seeing you. And I'm a clinical psychologist who has built my career around people with stimulant use disorders. I also want to thank Dr. Eaton and Dr. Springer for inviting me. So it's great to have you here. So where are we with the poll? Okay, mostly physicians. That's great. So we're going to, and nurse practitioners, physician assistants. We'll be talking a lot about medications as we move through here. So that's great. We also have a really nice representation of behavioral health providers. Awesome. So as we get going, let's see if I can make this go. Always happens. Okay. Here are our learning objectives. Today we're going to be, I'll be teaching you so that at the end you can describe the role of stimulant use disorder in HIV-related morbidity and mortality. We're going to talk about implementing contingency management and medication tools that can help treat patients with stimulant use disorders. An important point here is the and, not the or. We're not going to be talking about or no behavior therapy or medication therapy, because stimulant use disorder is hard to treat. It's really hard. And any of the tools that we can bring to our patients, we should try to do. We're going to talk about these evidence-based therapies for harm reduction as well, so that for folks who can't reach or don't want to be abstinent, that there's some health enhancing things that people can do short of that. We're going to start with a couple of pre-test questions. This is not a trick. I will go through these and unpack them at the end. But I'll be asking first, which of the following is a US FDA approved medication for addiction? So it's an FDA approved medication for addiction. Now, point of order here is some of these medications may be combinations or whatever. The question is, which one of these is FDA approved for treating addiction? Okay, let's see what we have. All right, so it's about equal between the C and D choices. Okay, we'll get into that toward the end. Thanks, everybody. And a little bit for topiramate and mirtazapine. Which of the following has the highest signal strength for treating stimulant use disorder? Pick one. Extended release naltrexone bupropion combination, mirtazapine, CBT, or contingency management. Okay, where are we with this? Okay, contingency management. Well, that's wonderful. I'm glad that people have been following the contingency management literature. It'll help with this talk. We'll get into this. So here is a graphic of where we are working toward. We're not here yet. but we're kind of on our way. When I say I see your patients on a different day than you do, that's true because they are the same patients who are using stimulants and also are living with HIV or are at risk for HIV and have other risks. And what we know is that all of the care that's organized around these sorts of folks is really in silos here. Carlos has been talking about this for a while. And you can see here that you have HIV care in a silo over here where PrEP and ART is dispensed. We have HIV testing and counseling that's right around the corner because these are infectious disease settings. Next is the silo for drug and alcohol use. And you have the whole issue of medications, behavior therapies, and harm reductions that are delivered in these specialty care settings. There's a movement to move these special treatments into primary care settings and to emergency departments, and a little bit more now to move these skills into infectious disease settings. We'll be talking about that. And then finally, what happens out on the streets in terms of sexually transmitted infection testing and treatment, not in clinic sort of things. And I put these silos there that what we're going to try to do over the next decade is to build these bridges, to actually reach the graphic that's at the bottom, which is from Carlos Del Rio's NASEM report, showing this sort of overlap between infectious diseases and addiction medicine, and that intersection in the two here to be able to grow the number of people who are competent at working at this intersection. So we'll be talking about that today. So we're going to start with some epi. We're going to get into, but before we get into the epi, what I really want to focus on is the point that stimulants have a purpose. And so in the lives of your patients, you've probably heard why it is that people start using stimulants. And, from my perspective in the West, we've always had stimulants as a major issue. The opioids have not been our big problem, especially around HIV. But we've always become familiar with the positive pieces of stimulant use. The physical and psychological upsides are listed here. The downsides are listed there. But there are also unique ways in which these drugs fit in the lives of people here, and you can see them around. I'll start at the top, gay and bisexual men. So stimulants can be facilitated into sex and the sorts of things that go on between gay men. It enhances sexual response. It also helps people who are living with HIV feel strong and in their body and to be able to feel like they used to. Moving down clockwise, you can see the shift workers who are involved in holding down two jobs. Many of our cities cost a lot to hold down the rent, and so it takes a couple jobs, and that requires a lot of energy. The stimulants really help people meet those needs. Bikers, as we continue around, stimulants have been a major part of biker culture. Breaking Bad, you can see how that works. It was moving up and down the West Coast in the crank cases of the motorcycles, which is why speed is called crank. But this drug, this stimulant, fit within the culture of gay men. I'm sorry, the bikers. Moving around, you can see women. It's not hard to figure out that women like stimulants because it helps them clean the house, it helps them be able to keep their weight down, and it also gives them energy to have sex with their partners when they come home at night. So there's a lot of emphasis among women who are using stimulants on those functions. Moving to the left clockwise here, or you can see rural folks and youth. One of the things that happens with stimulant use among these groups is it helps time pass. So, in places where there's not a lot to do, you can get high on stimulants. The time passes, particularly methamphetamine, which has a long half-life. You don't have to use it very often to make the day pass. And so the function of that drug in people's lives is really strong. And then finally, this is a new graphic that I've had to add to my presentation, and that is homeless folks. Stimulants are really important in the lives of people who are on the streets, transitionally housed, or experiencing homelessness or houselessness. The issue here is that being on the street and not having a place that you can sleep safely means that you need to make it through the night without getting rolled. And that's a function for methamphetamine in large respect, where people can stay awake during the night and sleep during the day. So I'm spending time with this to kind of teach you these cultural pieces so that as you're working with your patients, you know that as you begin to ask people to change their goals toward reducing or eliminating stimulants from their life, that you are respectful of the purpose of where this drug fits in people's lives. If you pull this drug out of the lives of gay men, you need to talk about sexual function and how to have sexual function going forward. If you pull the drug out of the life of somebody who's working two jobs, you have to talk about fiscal planning and how to live on half of the money that you can do with the energy that God gives our bodies. You know, you can see the point, and I won't go through all of these culture groups, but this is an important point. I'm a behavioral psychologist, and so I really focus on what is going on in terms of how this drug fits in people's lives. These are the latest data showing the numbers of US adults who report use of stimulants in the past year. And you can see here, there's cocaine to the left, the blue bubble, there's prescription stimulant misuse on the yellow bubble, and the red bubble is methamphetamine use. And you can see that there's a lot of people who are using stimulants, but there's not a lot of overlap between the stimulants. People tend to have an allegiance to their stimulant. If you look at what happens in gay and bisexual men, because that often is the place where we see stimulant use in infectious disease settings, we can see a very strong, high rate compared to heterosexual men of methamphetamine from gay to heterosexual men, or bisexual men to heterosexual men, almost 2 or 3.5 times the rate that you see in the odds in terms of methamphetamine use. I think it's kind of fun to also look here at, you can see it's less potent, high odds ratios here for cocaine. But this is a fun representation here of inhalants and seeing just the very high rate of odds ratios for gay and bisexual men compared to heterosexual men in the use of inhalants, which makes sense, right? Because the issue of the inhalants or poppers actually relax the anal musculature, which makes anal sex more comfortable. So you can see there's going back to that point about these drugs all have a place in people's lives and being able to be respectful. In terms of the epidemiology of what's going on out there, we know that these drugs are increasingly leading people to die. In US, this is Joe Friedman and Chelsea Shover's latest paper showing that fentanyl with and without stimulants is completely, like, there's so much death that's out there. By contrast, what you see here is heroin. The deaths attributable to heroin over the years are dropping, as well as for prescription opioids. This is really about fentanyl with stimulants. And you can see that when fentanyl starts, you start to see this really big increase here with fentanyl use. But when stimulants start in 2015, this actually becomes almost as strong an effect in accounting for drug deaths in the US. Now, we'll get to some of the issues about harm reduction. Death of methamphetamine use or cocaine use is not usually being overwhelmed by the methamphetamine or cocaine use. The deaths that are attributable to stimulants most often are due to accumulation to cardiovascular damage from sustained high-dose use of psychostimulants on the cardiovasculature. So it's heart attacks and strokes. So that's what's happening here. It's not so much about people overdosing on methamphetamine or cocaine out there falling over because they're overamping. It's usually because they're having heart attacks and strokes. And here is a really horrible picture showing just the rate of which stimulants without the opioids continue to increase in the overdose deaths over the past decade. And when you combine stimulants with fentanyl, the purple and the red bars, you can see that's almost half of cases currently up to 2021. I have local data here that shows that last year in Los Angeles County, 3,220 people died as a result of fentanyl or stimulants or the combination. That's 9 people every day dying. And to do the social math, you really have to go back and dig into the archives to find out when people were dying at that rate from diseases that weren't caused by viruses like COVID. And that takes us back to the early days of AIDS. And in fact, when I got into the field in 1992, I started working in this area because of the link between stimulants and HIV, because it was a place where I could bring my skills to be able to address the issue of people who were living with HIV, who were gay and bisexual men, and who were dying disproportionately or just horribly. You can see the mortality rate at the time was 72% of people who had HIV/AIDS were dying at the time. This is a back to the future moment. And it really does require us to start to move more aggressively and assertively within our infectious disease settings to bring health to folks so that we can kind of move on from where we started. The community is responding of folks who are using opioids. And you can see here that this is Alex Krau's data showing that of people who are using fentanyl in San Francisco. San Francisco was relatively late to the fentanyl game, as is Los Angeles and the rest of the West. And you can see here that when people started using fentanyl across the city, they started dying. And what the community did is they switched from opioid injection to opioid smoking. This is something that continues. And among people who inject drugs who are using opioids, there's often a smoking of opioids and an injecting of stimulants. So the needle still can be part of the picture of people who are using drugs, but it's much less with fentanyl. By the way, fentanyl is a game changer, and I'm sure Dr. Springer has talked about this in others on this series. But for those of us in the West, this is really our exposure to the opioid epidemic that's very much more common to the Northeast corridors. So we don't like it. Anyway, what we usually think about when thinking about HIV and stimulant use, it's about this intersection of sex and stimulants. In the literature, we call this chemsex, or what we used to call was sex on meth. Chemsex is a unique form of sexual behavior. It is different than I use methamphetamine or cocaine and then I have sex. This is more of a thing of it's a unitary, undismantleable, that's a word, type of behavior where the combination of sex, usually at the extremes and way more risky and intense than sex that men engage in when they're not using the drug. And the drug actually creates this experience that is not the same as having sex not on drug. So chemsex, the literature shows that there are substances that are associated with chemsex, and almost none of them are opioids. So there is a little bit of ketamine, but everything else is really more about stimulants in US and in Western Europe. There is a preference where, especially in US, among men who have sex with men from minority race, ethnic identities, cocaine is preferred for chemsex. That's shifting somewhat. There's data now that shows that methamphetamine is on the heels of cocaine in race, ethnic, minority communities. So, just don't, if you have someone who's sitting in front of you who is a white MSM, they're probably about as likely to be using methamphetamine as people from minority race ethnicities. So just kind of be suspicious of folks who are coming in, and if they bring up the issue of stimulants, just to inquire. And by the way, if they come in and they don't bring up the issue of stimulants, it's always good to ask. And then, this use, the chemsex phenomenon is more prevalent in MSM who are living with HIV than MSM who are not living with HIV. That's important. And I'm going to just kind of walk us through this very quickly. Here's a meta-analysis of chemsex. And you can see that in general, The antecedents of chemsex are listed here. It's social, emotional, events, physical. There are behaviors that engaged through here, including group sex, group sex events, increased unprotected sex, some injection of drugs and sharing of needles. And on average, across these studies, a range of 3 to 29% of MSM are engaged in this behavior. That's not a useful range, but we can say that in general, that if you have a gay man sitting in front of you in MSM, heterosexually identified man who has sex with men, it's always a good idea to inquire about stimulants because of these issues of the impact on mental health, the big risk of HIV and STDs, and impact on social functioning. This is such a long-standing link between this high-risk sex and HIV that these are old data from Explore, which is a HPTN study, and MAX, which is an ongoing cohort study showing that between 16 and 33% of incident cases of HIV are attributable to methamphetamine. So we've been seeing this in Los Angeles. We actually use the words, if you're using methamphetamine and you're an HIV non-infected man, it's a time to event that you will actually likely become HIV positive. So it's something to really focus on your groups and make sure that they're aware. There are similar sorts of enhanced risks for HIV incidence among people who use crack cocaine. It's not as strong an association, but it is there nonetheless. What we see among people who inject drugs, and these are data from the initial outbreak in Indiana, showing the increased incidence and spread of HIV through syringe sharing in that outbreak in Southeast Indiana. And you can see here that all the things that we saw in here were about a sharing of syringes, and that when syringe exchange actually opened in Indiana, then the incidence reduced. There were plenty of syringes that were dispensed and recirculated as clean. So those are important points. I want to show you just a little bit of data here from Los Angeles showing that this methamphetamine overlays other problems, including stimulants, syphilis, and HIV. And on this heat map over here, those of you who don't live in Los Angeles, this is the downtown Hollywood corridor. So the 101 freeway comes through here. And this is basically downtown. And this is the Figueroa corridor through South Los Angeles. This over here is the Northeast Valley, San Fernando Valley. And these heat cases are incident cases and clusters that of new diagnoses. What we see in here is that in these clusters, 18% of folks have a history of methamphetamine use, 11% history of unhoused, 2/3 having anonymous sex, and almost 50% are co-infected with syphilis. So one of the things we know is that in Los Angeles, that if you say methamphetamine in gay men, you're also talking about syphilis. So these are also these syndemic conditions that link together that we have to stay focused on in terms of thinking about stimulant use. This is not quite hair on fire moment here in Los Angeles, but we've seen this across the country, that since the pandemic has ended, that the increase of new diagnoses of HIV cases in most metropolitan areas is on the increase. And there's lots of things to talk about that, what's happening, but the point that I'm getting to here is data to care. These data say that we in the infectious disease community need to pay attention to stimulants. And that's the point. That's why I'm spending a lot of time here on what to do here with this problem to get us motivated to focus on it. And we're going to talk next about James. This is a case James is a 42-year-old Black African-American gay man who's seeing you because his partner John is saying he needs help. John complains that James' weekend warrior use of methamphetamine is interfering with their life together. James tells you this is impossible, as he is in long-term recovery from addiction to crack cocaine that he had in his early 20s, and he knows addiction, and this isn't it. He's perfectly in control of his meth use. James seroconverted 3 months ago. You started his HIV medication regimen, and he's responding well. James smokes cigarettes, about a pack or a pack and a half a day. In developing the treatment plan for James today, which of the following captures your best plan for his visit today? A, refer him to residential program for his methamphetamine use. Write a prescription. B, a prescription for James' cigarette smoking, either bupropion or varenicline. C, refer James and John to couples counseling. Or D, change his medication regimen. So vote your conscience in here. Lots of information in this case. It's not an unusual case. People have addiction histories, and these drugs change their experience. Really important point here is he seroconverted 3 months ago. So let's see what you guys are thinking, you folks are thinking. Awesome, awesome. We got a really good spread here, referring James and John to couples counseling, a residential program for methamphetamine. But I really want to focus here on writing the prescription for James' cigarette smoking. And why is that? Because in a study we did in the early part of the 2000s, Kathy Reback and I used a study using contingency management in gay and bisexual men who were using methamphetamine. About 2/3 of the folks who were in the study were living with HIV, about 1/3 were not. Along the way, recently, Colby Pissarro, who was an emergency medicine resident, and he's now a physician, came along and said, I want to follow up these patients about 20 years down the road to see what happened to them. He got public record death indices. We have those available in California, and was able to see that in terms of death outcomes, that the ones who had the best survival were people with HIV who were non-smokers, and the people who had the highest rates of the lowest rate of surviving in 20 years were people living with HIV who smoked. And in fact, you can see here, here's our crude mortality rates and our standardized mortality rates up here, showing that at each point, when you add one of these factors, that you actually increase the likelihood of dying. This point that I'm going to tell you is that these are data that show that addressing cigarette smoking in this population, where cigarette smoking and methamphetamine use are high rates of co-use of stimulants, that perhaps helping to move people to non-smoking status actually helps people prevent dying. So just something to think about as you move forward. And in terms of like recommending residential recovery for people who are not mentioning a problem with methamphetamine use, is usually not a good place to go, because people, it's always better to find out what people want to do with their methamphetamine use before you move into that sort of a recommendation. So just kind of looking, we just published some data on this a while back, and I had expected that somebody had written it, but they haven't. And this is the issue of the phenotype of what happens with people who use stimulants. Among gay and bisexual men, there's a group called the Weekend Warriors. They call themselves that. They start here on Thursday with a dose of methamphetamine. Usually it lasts 9 to 12 hours. They dose again on Friday. They show up to work sometimes. Friday afternoon, they dose again. They'll often pick up some erectile dysfunction drugs in this period, so that all of the abilities to have sex are there and enhanced. Saturday and Sunday, continuing the party or Saturday morning and night, they continue the party. On Sunday, they'll start to smoke some weed and then some benzo on the afternoon to slide into work Monday and Tuesday. This is a common pattern of what we see in terms of people who do weekend warriors. Weekend warriors are usually doing it not every weekend, but every 2 or 3 weekends. They'll do this sort of thing, which also helps makes it difficult to understand when problems require, when the methamphetamine use becomes a problem. Here's what it looks like for the shift workers who are dosing twice daily. This is really a fascinating sort of thing. One of the things we know is that the methamphetamine that's available on the street is pharmaceutical grade. It's above 95% pure, and they're using very high doses. So just for comparison, if you're using stimulants to treat ADHD, you're going to be using 60 to 80 milligrams of a potent stimulant. This potent stimulant that's out there, people are using about 1/4 gram a day or sometimes more. So that's 250 milligrams. That's 3 times the amount. We have some data now, some science that shows that at low dose, stimulants actually are helpful in terms of being able to meet goals for behavior without damaging neurons or neural processes. What happens when you dose your brain with 250 milligrams of high potency methamphetamine every day, sometimes twice a day? What you end up doing is you ratchet up the pathognomonic process that happens in the dendrites and the axons of the nerve cells themselves. And that causes all kinds of basic transmission problems in terms of dopamine transmission that takes a long time to clear up with abstinence. So that's a whole other area of research, but just kind of looking at, just want to make the clear distinction about dose. It's an important issue. We're dosing our brains here, and that you can see that sort of difference. And then for the men who are using methamphetamine on a weekend every 6 months or so, you can see the distinction. This is an important sort of distinction because it helps us to think about, well, if we have these phenotypes and we know that pathology is linked to dose and frequency of use, what are some harm reduction things that we could recommend to our patients that would have health benefits that may be alternatives to perfect response? The patients who I work with are not perfect. They don't often perform perfectly when they're engaged in treatment. So the issue of imperfect response is something that I've been interested in, and something that we published on this just last year, showing in a cohort of gay and bisexual men, half of whom are living with HIV and half who are not. And in that cohort, the half of the people who are in the cohort are drug users and half are not. So it's a 2-by-2, HIV by drug use. 500 of these gay and bisexual men living in Los Angeles. We've been following them for 10 years. And every 6 months, we ask them about their methamphetamine use. And they respond either none, they use monthly or less, or weekly or more, kind of getting that sense of that phenotypic behavioral representation. This difference in difference analysis across these variables show the odds of having all of these relatively bad things happening to them. And across the data, we saw this pattern from least likely having the condition for those who had no use, a little bit more for those who had some use, and most of the odds of having the condition for using weekly or more. And you can see that's for unemployment, housing instability, intimate partner violence, and so on down the way. And you can see also in terms of detectable viral load for people living with HIV, renal conditions, neurological conditions, and psychological conditions. The one place where we didn't see a difference was between living with HIV and not. That if you were using methamphetamine, you were statistically significantly more likely to have HIV prevalence than if you did not. And it didn't matter at any level of methamphetamine use, monthly or less, or weekly or more, you automatically increased your odds to becoming HIV prevalent. So what do we do about this in terms of addressing the issue of stimulants? Well, contingency management is an important piece to this. Now, why am I starting with contingency management? Today, online, you can download the ASAM, the Addiction Society of Addiction Medicine, and the AAP, the American Association of, or APPP of Psychiatry, Addiction Psychiatry. No, it's AAP. There is a clinical guidelines for the treatment of stimulant use disorder. It's the first time since I've been working in this field for 35 years, we finally have this clinical guideline. And the clinical guideline starts by recommending contingency management. So why would we start with that? Well, because contingency management is the treatment that has the highest potency of anything we have for treating stimulant use disorder, bar none. So the history of contingency management, it grew out of group homes in Kansas, where contingency management was used to shape the behaviors of delinquent boys. It is operant conditioning. It was applied first to methadone maintenance clinics by Maxine Stitzer at Hopkins. It moved into the field more broadly with Steve Higgins' group in Vermont by applying it to cocaine use disorder. And then we now have different ways of using contingency management in our clinics. There are two ways in the infectious disease clinic. This is probably the easiest, where you have a fishbowl. This is Nancy Petrie, who developed this method. She's passed. She died from an unfortunate breast cancer a few years back, but this was her idea to have 100 bowls, 100 slips in the fishbowl, and on the slips, 50 of them say good job. 30 of them say you get a low prize, 17 say a medium prize, and 3 a big prize for a urine sample showing negative for any stimulant, metabolite, or drug. So the first negative urine sample gives you 3 draws, and you increase by 1 for each consecutive negative sample to a cap of about 7 or 8. On the right side here, this is an escalating incentive structure. And you can see it starts with the first time you provide a urine sample that's negative, you get $5. And then the next sample during the week, you get $7.50, because you have a week of clear urine samples being provided. You get a $10 bonus. And for the week, you get $22.75 in either a cash or a voucher. This is a medium level contingency management strategy. And you can see that this is a way to actually help people to incentivize their behaviors to go 24 to 72 hours without using a stimulant, without being told what to do. It's allowing people the maximum level of liberty to figure out how they make it through that period. On this side, you get slips for prizes. On this side, you get urine samples. And it's this graphic here is presented because our patients like to call it peeing for dollars. So just kind of presenting that. And these are our data we published in 2005. This is the follow-up of that Colby Pissarro published on. And you can see here that conditions involving contingency management or the combination of contingency management and cognitive behavioral therapy significantly outperformed the standard cognitive behavioral therapy in 16 weeks of urine samples that are negative for methamphetamine use. Really, really amazing. And what is fascinating in here, this was just being able to have people come in, provide a urine sample, receive their voucher, and be told to come back next Wednesday or next Friday. They came in 3 times a week. So it was just fascinating to see how the power of these vouchers could actually help change behavior. And as we see here that as they change their behavior with their stimulant use, their unprotected, their sexual risk behaviors also pretty much zeroed out. And one of the really wonderful things is that even though they may have had some return to use to stimulants during the time, the risk behavior was pretty much zeroed out until a year later. One of the questions Ken Silverman asked was, what happens to people living with HIV? Can we actually use contingency management to produce viral suppression? And the answer is yes. In his proposal, Ken published these data showing that for people who were randomly assigned living with HIV to an incentive condition, they were significantly more likely to have undetectable viral load than people in a usual care condition in the clinic. And then the question was, well, is that because, this group up here are the people who are using a lot of methamphetamine? or other cocaine or other drugs. And so a secondary analysis of this shows that among the participants here who were drug negative and the participants who are drug positive, we see the similar sort of outcome here that for the incentive condition compared to the usual care. It had nothing to do with the specificity of responding to stimulants. So the take home from this is contingency management helps reduce cocaine use, and independently, contingency management can produce viral suppression among people who have a problem being virally suppressed. These are the effect sizes to contingency management. There's multiple systematic reviews on this question, meta-analyses, and you can see that the effect size of contingency management compared to standards of care is in the range of where we see responses to antibiotics. And it leads me to have this box here that says if contingency management were a medication, it would be standard of care. And that important point is why it is that in the standard, in the clinical guideline for treating cocaine use disorder or stimulant use disorder, we don't start with the list of medications. That comes later. Where we start is with recommending contingency management. Contingency management's been applied to all kinds of things. It's been used in being able to enhance response to post-exposure prophylaxis, and you can see here that gay men who are assigned to contingency management versus control were significantly more likely to complete post-exposure prophylaxis and to adhere to the medication. We also, Jesse Clark and Cherie Blair just published these data showing the contingency management can also have differential effects. You can have it address issues of tenofovir adherence among people not living with HIV and who are using methamphetamine. And you see a differential response here when you're incentivizing tenofovir versus on the right side, incentivizing methamphetamine. And you can see that there's, again, the superior response. So everybody agrees that contingency management's a good thing. It's what are the essential elements? Let's say you decided to start using contingency management in your clinic tomorrow. Well, it's going to take a little bit of preparation. Number one, contingency management is incredibly sensitive to the time between when you provide the biomarker showing abstinence and the reinforcer. Okay, the longer the biomarker and the reinforcer, the less likely to see the contingency management effect. You really want them to happen right next to each other. Okay, so that means that in your HIV clinics, in the HIV context, you need to have that immediate response. So sending off urine tests to the clinical lab that you provide that provides all your other labs is not going to be quick enough because those results come back 2 or 3 days later. That's going to be pretty much not useful for a contingency management program, which means you need to be starting to think about point of care tests. They're $1 a piece. They're really cheap, but in the clinics where you have quality markers regarding your lab services, you have to do demonstration of competence at all the levels. Whoever's using these point of care tests, it requires getting them into the clinic. It may require a CLIA issue, all kinds of other things that need to be worked out. So just to kind of put that into the mix here, that if you're going to start this, we really recommend the point of care test. You get the results within about 10 minutes, it's like actually 2 minutes, but it takes 10 minutes to get the urine tested and then reinforce it. You need access to pots of money to support the incentives. So that means you got to have grant writing ongoing for contingency management incentives. That grant money can come from the state, it can come from the county, the city, or foundations. I'm very happy to tell you that I live in California where we have contingency management available in a lot of places because our local stakeholders and our policy people said we need it here. And our folks here in California can qualify in any Medi-Cal sort of clinic for a contingency management program. and they can earn up to $599 in 1 year, which is of course $1 less than what you can make without having to do a 1090 form. So the idea here is we have the ability to have those contingency management incentives available, not only in Medi-Cal, but on Los Angeles County. Our stakeholders have made it so that that contingency management pot is available in any clinic that wants to incentivize people on stimulants. So I like to say, here's another example of how usually healthcare innovation affects first the higher SES folks. Here in Los Angeles and in the state of California, the people who have access to contingency management most easily are the people at the lower end of the SES spectrum. So very nice sort of representation of how we can move the needle if we organize everybody. And then the capacity to support repeated visits to the clinic. You really need to have people coming in twice weekly to provide urine samples to show that people are not using stimulants. Once a week is marginally acceptable. So that requires some change in staffing. You need to have kind front and back office staff persons, because we're bringing people in who may not be, may have incomplete response. And then you have to be able to manage vouchers or the prize cabinet, cash, those sorts of things. That has to be built in. So there's some work that needs to be done at the front end. There's Cherie, you have a question?
Oh, we'll take the questions at the end, I think.
Okay, all right. So there are some developments to help with people in terms of implementing contingency management. There's Reset and Reset O, that was Pear Therapeutics. Unfortunately, they're now off the market. This was something that was available. Dynamic Care followed and is filling that gap. It's a company that uses a similar strategy as the Reset and Reset O FDA approved contingency management incentive delivery program. You can see the pictures here. This is from their website. It has data. It has data that shows it's efficacious. This is the citation. And in the citation, you can see this is what the program looks like. You have a cell phone. It tells you how to do a breathalyzer. You perform the breathalyzer or provide the oral fluid for a drug test. The drug test results are pending, and then you get an outcome. You receive an award. It's all done there on your phone, and within settings that are not drug abuse settings. This is a really nice way of moving this forward. Q2I is another opportunity here. They have a program called ORS CM that's being developed. It's not available on market yet, but it will be coming soon. When we look at the effect size of contingency management compared to other behavioral therapies, this is a really important behavioral analysis, meta-analysis of behavioral therapies, showing the relative effect size of contingency management to, say, cognitive behavioral therapy or motivational behavior therapy or 12-step, all sorts of other different kinds of things. I think it's very interesting to see that treatment as usual actually has a fairly strong effect size and really is part of what we need to do. People will respond to different kinds of interventions for stimulant use disorder. And if you're comfortable with incomplete response, that's a really important thing. Here is also an example of how we use evidence-based treatment to address special groups within the population. In this case, it's gay and bisexual men who use methamphetamine. Kathy Reback and I worked. This is the specialized cognitive behavioral therapy from the data I showed earlier. These are available for free at the friendscommunitycenter.org website under the resources tab. This is the treatment manual, and this is the training manual for counselors. It really does integrate all the issues around the HIV risks, living with HIV and using methamphetamine, and really focuses on the aspects of this drug in the lives of gay and bisexual men and how to intervene. Okay, so switching, now we're going to switch directions here and talk about pharmacotherapy, medications. I'm not going to spend a lot of time with this. There's been talks about this already, but I just want to like reiterate the point. Just like I never do a talk without talking about stimulants and cigarettes. I'm never going to do a talk without talking about medication for opioid use disorder. I know out there in the community, there's this idea that the best outcome is detox, but that's how people are dying right now, is losing their opioid tolerance, getting involved with a drug again, and succumbing to to fentanyl and dying. So we really want to focus on MOUD and making sure that we facilitate ways for people who have opioid use disorder to stay on that medication, especially for people who are injecting drugs. Detox is not evidence-based. What about HIV prevention among people who inject drugs? Well, my colleague, Alex Dubov, and I just published this paper showing we did a study of prescribers of PrEP and tested their implicit association bias for people who inject drugs. We tested also their willingness to prescribe PrEP by having identical charts and changing the identifier, whether it was a person who injects drugs or whether it's a gay man. And what we saw was that prescribers are far more willing to prescribe PrEP to gay and bisexual men than people who inject drugs. And the reasons were because they believe that people who inject drugs are unlikely to adhere to the medication. And in fact, what we saw with the implicit association test was that a hypothetical person who injects drugs seeking PrEP in a primary care clinic had less than a 10% chance of encountering an unbiased clinician. This is an important point among people who inject drugs, whether it's a stimulant, whether it's an opioid, that we need to check our biases. There are no pretty TV commercials for PrEP for people who inject drugs at all. So this is an area that we need to focus on, and I'll stop talking about that. In terms of stimulant pharmacotherapies, this is an important point that's talked about in that question at the beginning, and we'll see it again at the end, is that there are no FDA-approved medications for stimulant use disorder. So what I'm going to be talking to you about are the medications that we have here that have a strong evidence of efficacy. Here is the practice guideline that you can download, and this is a great systematic review from Kristen Seyfried on medications for methamphetamine use. The evidence is strongest for the use of extended release naltrexone 380 milligrams every 3 weeks, not every 4 weeks, every 3 weeks, and bupropion, which is a mild stimulant, 450 milligrams a day. The number needed to treat at 12 weeks is 9, which is about equivalent to other addiction medications. And you can see that the difference between the medication and placebo groups overall is 11 percentage points. This is a complex design. The outcomes are measured in weeks 5 and 6. We randomly assign people 3 to 1, 3 times to placebo, 1 time to active medication. There are 403 patients in this group, so 300 of them go here, 100 go here. And we measure in here the percent of negative urine samples during this period to understand whether they actually responded or didn't. At the end of week 6, for the people who were not responding to placebo, they were re-randomized 1-to-1 active to placebo. So this is the second phase of the study. Here is the second phase of the evaluation. And what I think is fascinating is that this slope here is fairly equivalent to the slope here, showing a strong medication effect. That difference, when you weight this together, is that 11.1 percentage points. These data are under submission and a revise and resubmit, asking the question, well, at the end of this period, these guys stopped contributing to the analysis. What happened to them? And you can see about where they are in terms of their negative urine samples. That's what happens here. So you can see that's where they are here. And then in weeks 7 through 12, what we see is a continuation of the effect of the medication in helping people to produce more methamphetamine negative urines over the 12 weeks. We think this is fantastic. We don't understand exactly whether this is asymptote or whether this would continue going forward. We're going to use these post hoc analyses to propose an ongoing trial to look and see what happens in weeks 12 to maybe 24. We did Jeremy Kidd and Sabrina Smiley, mentees of mine, did a secondary analysis of these data and showed that for men who have sex with men compared to heterosexual men, there was a stronger treatment effect for the gay and bisexual men compared to the heterosexual men. It was statistical. And you can see here the numbers in this secondary analysis is large. So Dr. Kidd has submitted another prospective study to see if this secondary analysis works. But what we know is that this medication combination, it works, and we're not quite sure why, but it's the first and the strongest signal of any medication effect in over 30 years of addiction research. Highly powered or fully powered. The primary outcome is clear. This is a significant dose of a weak stimulant. And in fact, we also have a paper showing that this medication combination actually also reduces cigarette smoking, which, as we know, bupropion is Wellbutrin, and it is a approved treatment drug for smoking reduction, smoking cessation. And we don't know what's going on here. Is it the mu antagonist? Is it the kappa antagonist? We don't know. We think it's probably something about the synergized effect of this stimulant and the mu antagonist. An alternative with methamphetamine is mirtazapine, 30 milligrams a day. Mirtazapine is approved antidepressant. This is the first trial that was reported among gay and bisexual men and transgender women by Grant Colfax. And you can see here that the slope and the reduction of positive urine samples is significant compared to placebo. This was replicated by Philip Coffin a couple of years ago, showing a similar slope in positive urine compared to the placebo. With Dr. Coffin, he continued the study for another 24 weeks and saw that there was really no increased response to mirtazapine through this period. The meta-analysis of these two trials show that there's a significant effect of methamphetamine positive urine toxicology screens at 12 weeks and has no effect in terms of retention and treatment or depression. As we said, mirtazapine is an approved antidepressant, but that's not the mechanism by which this drug is reducing methamphetamine use. So why am I excited about mirtazapine for methamphetamine use? Well, the hardest thing to do in science is the same thing twice, and these folks did it. The slopes of the meth reduction are pretty much parallel. The mechanism is not antidepressant. It's probably more about the restoration of sleep architecture. We see that this is really what happens. People report sleeping better with mirtazapine, and that slow wave restorative sleep help not just amount of time, but actually the quality of sleep is improved, which may help people. There are some downsides of potential weight gain, and there's an ongoing trial of this in broad population in Australia. One of the questions I often get is, where do I start? Mirtazapine, you usually want to ramp up to 30, so you start at 15 and then move up to 30. The answer to that question is you don't do that. You start at 30 milligrams. That's what the evidence shows us. And there's really no benefit to starting at the 15 because the weight gain and sleepiness effects are really much more pronounced in the lower dose compared to the higher dose. For cocaine, we have, again, two studies showing the similar outcomes here for mirtazapine, 200 mixed amphetamine salts, extended release, Adderall, 60 milligrams a day, plus topiramate, 200 milligrams a day. Topiramate is an anti-epilepsy drug. Mixed amphetamine salts is amphetamine. It's used for the treating of ADHD. And you can see here that in folks, these are folks who are cocaine use disorder and ADHD negative. You can see that about 33% achieved 3 consecutive weeks of negative cocaine urine samples, a very difficult bar to reach. And you can see in placebo, that's about twice the amount of participants who achieved that rate. Francis Levin replicated this and showing in a 12-week trial, again, the same reduction of positive cocaine samples in the treated group versus the placebo group. So what do we know about this? Well, we know that, again, it's the same thing done twice, very hard to do, strong evidence of using a treatment combination. It's a mechanism of response issue here in terms of, you've got a replication trial ongoing, and we see similar sorts of slopes. So one of the downsides of mixed amphetamine salt 60 milligrams plus topiramate 200 milligrams is that many clinicians are uncomfortable prescribing stimulants, even slow release ones, to people with cocaine use disorder. There's something called the Harrison Treatment Act, which says you cannot use a stimulant to treat someone with stimulant use disorder. So one of the things that we really focus on here is trying to address questions of ADHD. We want to be able to use this combination and be able to do it. It does raise the question of treating ADHD as well as stimulant use. There is a high rate of comorbidity of people with ADHD who are using stimulants, either cocaine or methamphetamine. And you hear this when they say, these medications help me to slow down because they help me focus my attention, which is how stimulants work in the treatment of ADHD. Stimulants don't take people with ADHD and turn them into people without ADHD. They just basically help people with this condition to concentrate more. Most clinicians feel comfortable best referring the use of a stimulant for a treatment for somebody with stimulant use disorder to a psychiatrist. I would also recommend that that would be the case so that there can be an assessment of ADHD, whether it's in an adolescent, young adult, or an adult, which would give you some reason to use the stimulant and to combine it with topiramate. That's also part of the reason why many clinicians will actually use topiramate by itself as opposed to with the combination to address cocaine use. And there's some evidence for that. It's not as strong as the combination. So it leads us to the second case here. Your patient is a 37-year-old Caucasian woman, Jolene, who's been using fentanyl and cocaine for the past year. The fentanyl on the streets is so strong. For 6 days, she was so high on fentanyl and cocaine, she was unable to move. She sat in her own waste outside a metro stop. This caused infections in her urinary tract and opened skin wounds around her anus that now contain maggots. When she lost consciousness, her fiance called 911 and Jolene was transported to the hospital where she was cleaned up and treated with IV antibiotics. You've managed Jolene's opioid use disorder with buprenorphine sufficiently that she's not eloped from hospital. And during her week, you ordered an HIV test, and guess what? She tests newly HIV positive, 1.2 million copies. You began treatment for a new case of HIV infection. And as part of your treatment, as your comprehensive treatment, what is your plan for addressing Jolene's cocaine use disorder? Do you do nothing? Do you refer her to social work for dispo back to community? Do you start medication, the mixed amphetamine salts and topiramate, or do you get Jordan to drug-free rehab? So go ahead and vote your conscience here. Okay, let's see what we got. Start medication. Awesome. I love this. This is a great group in terms of being willing to move forward with medications. Awesome. Great. Okay. These are the alcohol medications. I know you have a specific session on alcohol, so I'm just including these for your reference. And just to go through here and kind of talk about what's going on with the medications. We have strong sustained effects for medications for opioid use disorder, and they should be used. Mirtazapine effects in MSM are impressive. The replication study is impressive as well. The effect is in reduction in use, not abstinence, as well as the case in the extended release naltrexone bupropion combination over placebo. It's about reducing use, not necessarily abstinence. Strong evidence of use for antipsychotics for psychosis. I don't go through these data, it's in the clinical guideline, but if you have somebody who has psychosis and is using stimulants, treat the psychosis with an antipsychotic before you address the ongoing cocaine use disorder. Some evidence of symptom relief for withdrawal, and the mixed amphetamine extended release and topiramate for cocaine use with replication studies. So I leave this photo here to kind of give you a sense of this. These medications provide a foundation for treatment. For substance use in HIV settings, it's not a whole house. You're going to layer things on top, going back to that first image about like the silos, being able to think about building on top of this foundation, that the health impact is really improved by having more people addressing stimulant use in these in infectious disease settings. So I just want to like walk through some issues around harm reduction, because we're coming to the end here. These are data on the medical care coordination outcomes in Los Angeles County. And you can see that before people come and start medical care coordination, there's a reduction in the probability of viral suppression. They start, and is an immediate increase in the odds of becoming virally suppressed, but not all people respond equally. We can see that folks who are using stimulants and who are housing unstable are somewhat less responsive than people who don't have any comorbidities. We also see that in the medical care coordination that the outcomes for Black patients are lower in terms of viral suppression in people with low, moderate, and high quantile of SES and the problem severities. You can see, so this also makes it important to data to care to focus on African American patients and to be able to think about what to do with them that might increase their ability to retain viral suppression, especially if they're using methamphetamine. Viral suppression among people who inject drugs is lower than among other subgroups. This is from our CDC's HIV surveillance report, again, showing that if people are injecting stimulants, the idea here is to build upon foundations to be able to address stimulants. We can see the contingency management is incorporated in prevention. This is Project PROP that was started in San Francisco at the San Francisco AIDS Foundation. A lot of contingency management programs have been built around HIV prevention and are funded through HIV prevention dollars. Just a heads up on that. And these are data that show that the contingency management program helps people to produce cocaine-free negative urine samples. Just this program continues. We started this with Jeff Klausner in the early 2000s in San Francisco, and the program continues. We have other ways of bringing integrated care to where people are at, including HPTN 094. I know Dr. Springer is also doing something like this, using an integrated mobile health clinic that addresses HIV, infectious diseases, addiction services, psychosocial treatment, and navigation. This is our design. And this is the advantage of a bus taking care to where people are at. This is the Vignes housing site in Los Angeles. These are shipping containers that have been altered to be able to accommodate people who don't have a place to live. This program was instituted, it was stood up in 6 months, which is really a wonderful thing to see, that something can be quickly done to get some people some housing to get in from the cold. We have a focus now on drug checking, taking an FTIR. This is a very sophisticated drug chemistry analysis program. It's not quite GCMS, but it's pretty close in terms of being able to take substances and be able to figure out what they are. We also do things like fentanyl test strips out where we do drug checking. And the whole idea is to give people information about what they're using. It's a very interesting story, and it just helps to reduce risk and improve health. Over-amping, focusing on helping people to address the issues of stimulant intoxication, to drink water, to avoid smoking before injecting drugs, avoid combination of stimulants. You know, these are important things to do to avoid overamping, and it's something that we want to think about as within the infectious disease setting. We also have new things coming along, like using oral naltrexone and oral TDF-FTC for gay and bisexual men who are partying. They take this before they go out, and it helps reduce amount of alcohol use, and it also improves HIV protection. Integrated contingency management into prevention settings that address stimulant use. We went over some of that a little bit. Using telehealth resources to deliver PrEP to groups who won't access PrEP in standard settings, particularly young Black men and young Latino men. Scale up of HIV testing in emergency departments and urgent cares. This is a no-duh. It's been a recommendation from CDC since 2006, and it's still not widely implemented. And then community-generated strategies for Black, African American, and Latino communities. So in sum, we're sliding into the end here, where the prevalence of stimulant use virtually assures viremia at the population level. That's an important point. We have to do something to get viremia down among people who are using stimulants, and contingency management is a great way to do it. There are interventions with less efficacy that are more commonly found out there, like talk therapies that have no or little evidence of efficacy. There's very little addiction medicine that's out there in our clinics, but we need to start that, being able to address opioids, stimulants, and alcohol. And we talked about contingency management. And the next phase of the work is the how-to work, how to do this in the HIV context when we're taking care where people are at. So I want to return back to our opening questions here. Which of the following is a US FDA-approved medication for addiction? Remember, there are medications here that have some efficacy, but which one is approved for treating addiction? Okay, let's see what we have. Okay, so the correct answer here is C. And the reason is that extended release naltrexone is approved for the treatment of opioid use disorder and alcohol use disorder. The combination of the extended release naltrexone plus bupropion, which is choice D, shows efficacy, but it's not FDA approved. Question 2: which of the following has the highest signal strength for treating stimulant use disorder? The combination of extended release naltrexone, bupropion, mirtazapine, cognitive behavioral therapy, or contingency management. Okay, let's check our findings here. Awesome, contingency management, right? So some of these other choices have evidence of efficacy, but the strongest treatment here is contingency management for stimulant use disorder. Awesome. So yes, exactly. There are numerous meta-analyses showing the signal strength that is much higher than the comparators. Even though there are medications that have efficacy, there's nowhere near the same level of signal strength as contingency management. So I'll stop here, and it'd be a great time for questions.
Yeah, awesome, Steve. That was an amazing tour de force. And there have been quite a few questions, and I know we have about 13 minutes, and I'm just going to kind of focus on some of the big ones, which are mainly focused on contingency management. One question is, in addition to, other than monetary incentives, what would be some incentives that you could suggest for someone who's interested in incorporating this in their clinics? This was one question.
Great question. So incentives can be all kinds of things. So I've used incentives like a Carl's Jr. gift card. So sometimes people like, or Starbucks gift cards or things like that. Those are very handy and they're portable. You can keep them in the office and it's not hard to do. And you don't have to give a Visa card. Another thing to do is get a prize cabinet and just have like a few low value, so like sweets, gum, hygiene supplies, whatever it might be, condoms and lube, whatever it might be that you put on the low value A medium value that would be something like maybe a dinner out ticket to Olive Garden or something like that. And then a high value, which would be something like maybe I don't know, maybe a TV set or something like that. But something
Yeah.
like, yeah.
So and then, even perhaps, although it might not be as valuable, but to some people, even having, a certificate or other, laminated, framed, um,
People like their certificates. Yeah,
yes,
they
yes, I've used that myself, but yes, I agree with you. A couple of questions, I'm going to put them together, are, how long this came in, how long would one continue contingency management? And then the other one is what happens when the contingency management is completed? And so I don't know if you want to address that. I know we always see this in research, there's only so long studies can go from funding, but for opioid use disorder, I always say you treat the patient for as long as they need it. There's no evidence to support medication treatments for opioid use disorder have deleterious outcomes and medication, from a physical standpoint. So keep going. But I guess the questions for contingency management, and wondering how long you should go, and then what happens when you stop it.
So great question. So most of the data are on 8 to 12 weeks. There's very little data of extending contingency management programs beyond that. What we know is that contingency management, if you think of it as a medication, when you stop delivering the contingency management at 8 or 12 weeks, you'll start to see erosion of effect. That's the same thing that would happen is if you stop the medication, you would start to see an erosion of effect. So one of the questions here is not about like, is that a bad thing? No, that actually shows the evidence that the contingency management is working, as you would see it in the same sort of parallel logic for understanding medication effects. So one of the things you can do then is like, this is an area of research that's developing. So one of the things you do is you just make available for people to come back in when they need. There's often a return to use, to stimulant use. But one of the things that happens is people who reduce their stimulant use rarely go back up to where it started. So people who get a handle on their stimulant use problem can generalize that. In California, one of the things in San Francisco they've done is they've linked the contingency management program to the front door of a treatment program. So people actually get their stimulant problem under control and then start talking about things that need fixing in their life. And that's so it becomes almost it's an entryway into treatment that people would otherwise not make.
Great, thank you. And then some other individuals are asking, well, what do you do? There's a mixture of drugs. It's not just stimulants. And what do you do? And how does this affect your approach to treatment when one of your patients are utilizing multiple substances? And I know you've touched upon this, but and we've talked about this in the treatment of opioid use disorder lecture that, we don't stop medication treatment for opioid use disorder if you're using a stimulant, but how would you address kind of multi or comorbid substance use disorders or substance use?
Yeah, great question. So if someone's using opioids, you put them on medication for opioid use disorder, and that's independent of anything you're going to do next. So you start them there. If you start, the literature on contingency management for opioid use disorder is not strong. So this is really an important point that this intervention really addresses stimulants primarily. There's a little spread, but not so much. So if you've got somebody who's doing cocaine or methamphetamine, you can actually cross test. So any stimulant use, whether it's a cocaine positive or a negative positive, is not going to be reinforced. Or by alternately, if you have both of those being negative, then you reinforce. And if one of them is positive, then you don't. So that'll work. That's the best way to address that. It's not going to necessarily. I've not seen any data that like addresses benzos or any sort of other sorts of drugs. So yeah.
Yeah, no, it's really complicated. And as we're seeing, more overdoses and a combination of medications and others, it's been very difficult, especially here Connecticut where I'm at with xylazine, et cetera. And we don't have
Yeah.
treatments for, as we're starting to see. So that was good. A couple of questions specific one to California. I think someone heard that you had said that they were not aware that contingency management programs were available to patients with Medi-Cal. And how do you get info on that? And maybe we could add that to our slide set unless you have information about that.
So it is the Cal ODC, Medi-Cal Contingency Management Program. And I'll get you the links on that about how to hook that up. Brian Hurley is our local person who manages this, and he has made a commitment. Even if you have a clinic that's not in the Cal ODS system, he will make sure that those vouchers get to you if you're willing to do them.
Oh, that's great. And he's the president of ASAM, right? So
That's right. Exactly.
so just I just saw him at AAAP and so that's great. And we could add that to maybe your slide set, which just to remind everyone will be available 24 hours after this on the IAS-USA website. There's some other questions about that were kind of written in that I just wanted to ask is, and this is the real world, and you may not be able to answer this, is how to respond to a shortage of providers for stimulant use disorder, harm reduction, contingency management in our HIV care setting. So I think what I heard from you, and it's a big area that I talk about too, and Ellen Eden, who's on this, is this idea that we need to integrate and is all hands on deck. And how do you get how do you get people to want to treat substance use? And particularly here, we're talking about stimulant use, and also providing harm reduction services in your setting.
So the biggest issue to get past is the champion issue. I mean, having the champion in the clinic is going to help with all, because everything else is just an implementation problem. So, I've been doing this for a while, and it's like, if the doc who runs the clinic says, we are going to do this, then everything will orient. But it's still difficult to get those vouchers in place, to get that urine testing technology down, to have the front desk people oriented to this. So those are all real world problems. And there are ways to do it, but it requires that champion to say, we are just going to power through this, because there's nothing other than that champion that will actually move that needle.
Yeah, it's an excellent point, and that has actually come up previous. And Dr. Eaton, who is not shown, I don't know if she's here, but really doing that in University of Alabama in her clinic and integrating those and others. And so I think finding that champion and really talking, getting everybody on board is important. But having done doing ID for many, 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 many years, it's still hard. But yeah, keep going. I think we're seeing more and more people kind of coming on now. I know we only have a couple more minutes. There's some really other questions in the chat. I think one that you've already touched upon is, are there the stimulants that are more associated with risky sexual behaviors, condomless anal sex than others? I think you touched upon this. Methamphetamine was, yes. Could you explain the Harrison Treatment Act? Why doesn't that apply to opioid agonist treatments for treatment of opioid use disorder?
It does.
Oh,
okay,
so that's one question here.
Right. It's a little more nuanced than that. So buprenorphine can be used in settings outside. A doctor can prescribe buprenorphine very easily, but methadone cannot. So it has to do with the methadone. It's the agonist piece of this that invokes the thing. And that's why, you can prescribe methadone in the hospital for a patient for anybody can do that. Right.
Right.
But you can't do it once that patient discharges. So that's when the Harrison Act comes in. So okay. That's what happens there.
Yeah, I'll just ask, there's another question. I think it's important, and you touched upon it. It came in as a written question previous to this, but are there measures for screening for stigma associated with crystal meth use among patients using meth, and ones that you would recommend for providers and how to address that.
So I can give you some links
Maybe
to
we could put
this.
that in the
Yeah,
slide.
I mean,
Okay.
it's always great. That implicit association task is really good, to be able to kind of get a sense of the sort of the stigma there. And we have some measures that we use that are pencil and paper here as well.
And one about, are there any evidence-based interventions for sexual and gender minorities using crystal meth that address both substance use, HIV prevention, and HIV treatment engagement specifically for that population?
Yeah, that you can get that out of the getting off manuals, that are in the Friends Community Center website, and you can download those. Those are evident. Those are like Best Debbie's or something like that now, whatever they're called. You know, they're best practices. There's plenty of data on their efficacy. So, and they address all those issues.
Yeah, and we can add maybe links to those in the slides if not there. But
right, there's also some transgender specific materials. I can
good.
also make some links to that as well. So
Great. We only have 1 minute left. I just wanted to say there are other questions and just want to say this was awesome. And we do need more of this. So anyone who's actually been thinking about it, you want to start treating stimulant use in your HIV care setting, lots of amazing resources, people to help out. And you know, it just takes one. So really appreciate it. Dr. Shoptaw, for your talk today.
I really am in debt to you, Dr. Springer, for bringing this up to make it such an important point. These are where our patients live, and it's so great that you've elevated this discussion.
Yeah, all in IAS and USA, and we'll have to chat more about our mobile health interventions because stimulant use, we need a mobile
Huge. Yeah, exactly.
to help improve PrEP and ART and substance use. So I know that we have some ending slides that I was going to end with for those of you who are still with us, and I think the organizers will bring those up for me. And if not, or do you want me to or not? I don't know. I don't see any slides. Oh, there they are. So quickly, you know, that if you could, this is just to remind you, evaluations and information, how to claim your CME will be emailed to you by 5 p.m. Pacific time, 8 p.m. Eastern time tomorrow. Oh, this is a great talk. Don't miss this one. Going antiviral, the new IAS-USA podcast with Dr. Michael Sag and Dr. Fauci. Can't miss that one. And then another one here, going antiviral, and a deep dive into vaccine development with Dr. Richard Koop. Also looks awesome. And here's another session coming up, the pathogenesis of long COVID. And last but not least, big plug for the part 6 of our 6-part series on substance use disorder in patients with HIV will be moderated by our Dr. Ellen Eaton. And the presenter is Dr. Michelle Loftwell, and we'll be talking about future directions of long-acting injectables, in particular medication treatments for opioid use disorder and novel therapies in people living with HIV. And there is another session coming up if you want to hear Dr. Eaton and I chat and answer some more questions. There's another session coming up in February 6th. And in person, if you are interested, the next talk, IAS-USA session in New York, I'll be there talking about substance use disorder management and people with HIV, and then lots of other folks. And then Atlanta, Georgia, there'll be one in person if you want to go there. So thanks again. Sorry we went over a little bit. It's really been a pleasure, and really appreciate all of you for joining. And if we didn't get to all your questions, feel free to reach out and we'll respond. And the talk will be available tomorrow. Take care.